Hello everyone. Our topic for tonight will be evaluation of fever in the returning traveler. And my interest in this topic actually comes from the fact that more and more people are traveling. And since more and more people are traveling, we're seeing more people coming back sick, especially with fever. Now, in preparation to this talk, I had to refer to many different sources. But the main sources that I got information from included the JO Sentinel website, which is the global surveillance network of the International Society of Travel Medicine and the CDC. And also by reviewing a few papers, most importantly is a paper by Dr. Friedman published in New England Journal of Medicine 2006 with the title of Spectrum of Disease and Relation to Space of Exposure Among Ill Returned Travelers. And another paper by Dr. Leggett, Professor of Public Health and Tropical Medicine, James Cook University, Australia, with the title of Assessment of Febrile Illnesses in the Returned Travelers. As I mentioned, international travel continues to grow. More than 50 million travelers move around each year. And people are traveling more and more to places that have not really been visited in the past. And in doing so, they continue to face a shifting target of infectious diseases, where some places have become safer, in others new infections have emerged and older ones have re-emerged. Approximately 4 million people each year are ill enough to seek health care, either abroad or upon returning home. That being said, the assessment of these patients is often hampered by basically the clinician's lack of familiarity with the types of infections that these patients have encountered while traveling. And again, just a note how common the problem is. Up to 64% of travelers to developing countries report some sort of a health problem. Doesn't have to be fever, but they are sick with an illness, basically. Fever is a common symptom, with or without other symptoms and signs. And as we all know, it may be a manifestation of a minor self-limited process, or it can be just the beginning of a life-threatening illness. And a lot of times our initial evaluation or exam may not really distinguish between the two. So it seems logical that a systemic approach is important, and I thought it's very relevant to what we do here in the Division of Infectious Diseases and International Medicine at the University of South Florida. So upon doing a lot of reading and reviewing all these different sources and how people and specialists approach this problem, they seem to focus on trying to answering three basic questions to arrive at the most probable diagnosis and initiate treatment on their patients. Question number one, basically what infections are possible given where the patient has lived or traveled and the time when the exposure has occurred. So answering this question basically need us to have a little bit of knowledge about the prevalence of diseases in different countries all around the world, and also their mode of transmission, to be able to determine the correct exposure and relate it to the probable infection. And after determining that, now we have the second question, which is basically which of these infections is more probable given the patient's clinical findings and potential exposures. And trying to find an answer to this question, the person would probably need to have some basic information about the manifestations of all these different diseases and basically the clinical syndromes they can present with. And finally, hopefully by identifying these 2 points, we can answer our most important question, which is which of these infections is treatable or transmissible or both. To be able to answer these questions, we probably want to know a little bit about epidemiology and etiology of these diseases, and where can we find the causes of all these different diseases and all these different travelers is basically to look at studies where data are extracted on these travelers. And actually a number of studies have evaluated the epidemiology of fever in the traveler returning from a visit to a developing world. But by far the largest contemporary experience in illness related to travel to developing world comes from JO Sentinel. GeoSentinel is the global surveillance network of the International Society of Travel Medicine and the CDC. And what they're basically clinics. They are travel clinics located throughout the world. And they see patients who come back sick from the developing world, and they collect basically data on them, and they keep this data, and then every few years it gets analyzed. Right now we have more than 45 GeoSentinel sites or clinics. They're located on 6 continents. So in trying to have a better grasp of the epidemiology and etiology of these diseases in travelers, one would be very interested to look at their data and see what they found. The most recent report is from 2006, from 30 GeoSentinel sites in developed countries. Now, most of these clinics, they actually are located in developed countries. Also, they see people coming from the underdeveloped world. Only a few sites are available over in the developing countries. So in 2006, a report from 30 sites provided clinical surveillance information over 17,000 travelers who returned sick from developing countries between 1996 and 2004. The first thing they found that the primary manifestation of a sickness in the majority of these travelers could actually be placed in one of 5 syndrome categories. These categories are, they can present with a systemic febrile illness, acute diarrhea, a dermatologic disorder, chronic diarrhea, and non-diarrheal gastrointestinal disorder. And I thought, boom, this is like the first step in trying to arrive at a diagnosis, where you put your patient in a syndrome category and you basically go from there. And the majority of the patients will fit in one of these categories, and all you have to do is basically then look into the category on what are the possible differential diagnoses and so forth. And I just highlighted the febrile illness because that's the topic for tonight. So we're not going to be going over the rest of the list. Now, for fever, they looked further, and they analyzed data on people who had fever as their symptom of presentation, which was 28% of their patients at that time. And the following were found. The most common specific fever diagnosis, and this is lumped together. They didn't look at specific sites. They just looked at all these travelers throughout the world who were sick and what was the causes of their fever. Can you tell me, Rachel, what was the commonest? I knew you would know that one. How about the next one? Yes. Malaria and dengue more than a third of the time. And now we're looking at, I want to attract your attention, we're talking about specific causes of fever. There are some other fevers which nobody really find etiologies for, but we're looking for basically pathogens that we can identify and treat and so forth. So here you go, 1/3 of your patients will either have a malaria or dengue. By far, malaria incidence was higher than dengue, but the incidence of dengue may be underestimated. Can you tell me, Yuli, why dengue may be underestimated or underreported? Can be. Give me a couple of strong reasons where dengue never really made it to. Excellent. Dengue has a short incubation period, and majority of the time it's a mild illness. So by the time the patient, feels the fever, they pretty much quickly get stronger, better, and they never really sought medical advice, so they're not really in that data system. So here you go. Specific diagnosis: malaria, dengue, more than a third of the time. In another third, the reason for their febrile illness was either a diarrheal illness, acute diarrhea, or a respiratory infection, 15 and 14% respectively. The rest, no specific diagnoses were found. So we're looking at all these numbers, all these data, and we're trying to figure out what caused their fever. And we have our specific diagnoses, the commonest, and then the other non-specific diagnoses. The report also indicated that 17% of these febrile illnesses were either preventable by a vaccine or by chemoprophylaxis. For example, a vaccine-preventable disease like Salmonella typhi, hepatitis A, influenza, or chemoprophylaxis in the case of falciparum malaria. The report also found that almost half of these patients who came in with a systemic febrile illness required hospitalization, and they also told us where these sick travelers came from. Majority of patients going to these travel sites or geosentinel sites came from Sub-Saharan Africa, travelers coming back from Southeast Asia, Caribbean, and Central and South America. They further analyzed the data at these individual sites. So what did they find about travelers coming back from Sub-Saharan Africa with a fever? It deleted some of the... Yeah. I'll just keep going. All right. In people coming... well, here was supposed to be actually a map showing what is Sub-Saharan Africa. So kind of important here, but that's fine. The travelers coming back from Sub-Saharan Africa who were sick, almost half of them had fever. So that's a pretty high incidence of fever, and I want you to note that because when you look at other sites where people can come sick with, fever is not that high. But Sub-Saharan Africa fever is one of the commonest presentations when people come back sick, and almost half of the cases were malaria, and 10% respiratory illness, 10% fever and diarrheal illness, and no diagnosis in 19%. In addition, most of the Rickettsial infections that they found from all these travelers actually occurred in this part of the world, Sub-Saharan Africa, and majority were, and yeah, they were usually tick-borne. Oh, now it comes. So just did it the opposite way. Basically the map, the highlighted area, the shaded area shows what's the region in the indicated by Sub-Saharan Africa, which is basically the countries south of the Sahara Desert. So. Looking at Southeast Asia, shown here in the map, when people came back ill, 34% had a systemic febrile illness, and dengue was specifically diagnosed in 18% of the time. Again, we're thinking maybe an underestimate. Malaria, 7% of the time, followed by respiratory, diarrheal illness, and fever, and no diagnosis for their fever in 22%. I want you to note that 70% of all the travelers who developed typhoid fever were actually coming from this part of the world. Typhoid, paratyphoid were acquired in South Central or Southeast Asia. Caribbean, Central, and South America, people who came sick, 25% had a fever. Dengue, right there. Malaria, followed by respiratory and fever, diarrhea and fever. And I just want you to note how malaria kept appearing in all of these single sites. Other pathogens have also been reported. They did find and report other pathogens. They were just not as frequent as the ones that just mentioned. These include chikungunya, agents of chikungunya fever, leptospirosis, and fungal infections. Other infections are quite rare, but they wanted us to know that they actually still were reported because the majority of them are actually treatable, and if missed or not treated, can be fatal. Diphtheria, with the waning immunity of the adult population, you probably may encounter people coming back sick with diphtheria, even things like rubella and so forth. Amoebic liver abscess made it to the list. Q fever, brucella, visceral leishmaniasis, African trypanosomiasis, melioidosis, rabies, and relapsing fever. Again, all can be fatal, but all treatable, except rabies. So now we have a little bit idea about the epidemiology, what is found where, and what are the incidences, and so forth. What we're going to do is just, this is not meant to be any detailed review, but just a brief review of some of these common illnesses. Malaria. A concept for seeing patients coming from malarious regions. Any patient who has spent any considerable time or any time at all in a malarious region and gives a history of fever, even if they're not afebrile, when they come for evaluation should be tested for malaria. One thing to remember about malaria, fever waxes and wane, and sometimes at the initial presentation they may not really have fever, and also their physical exam will be completely normal. It's a common disease. It occurs throughout the tropics, and it's a parasitic disease, causes more than 300 million cases a year, with 300 million deaths, with 3 million deaths each year. The causes, as we all know, falciparum, vivax, malaria, and ovale. But note that worldwide, Plasmodium falciparum and vivax account for most of the recorded malaria. Malaria caused by Plasmodium falciparum has a short incubation period. It's the shortest of all the species of Plasmodium species, and usually it presents the first month, basically, of coming back from travel. And but bear in mind that the presentation may be delayed if the person is on suppressive antimalarial drugs. Vivax, by contrast, has a longer, we all know, has the relapsing phase and all that, and may not really present that quickly. The patient may have manifestations months or years after exposure. Also bear in mind that complicated malaria is a great mimicker, so they may come with very bizarre presentation or complicated course. Right now we're diagnosing malaria with seeing a parasite in the blood film, detecting circulating antigen, and I know now we have available also the PCR technology. And remember that the peripheral films may be negative, and we really should be repeating these peripheral smears every 36-48 hours before we can confidently exclude malaria. And always, if you diagnose the patient with malaria, refer to the current guidelines because of the for treatment purposes, because of the resistance issues. This map was just meant to show the prevalence of malaria. As you can see, pretty vast area here, and the dark color shows the prevalence of chloroquine resistance. So probably be unlikely to give someone chloroquine if they return with malaria from this region. In South America, Mexico, Haiti, Argentina, chloroquine susceptibility is still the rule. Others, Brazil, Bolivia, Peru, Cambodia, Venezuela, chloroquine resistance is the rule. Moving on to dengue, flavivirus, largely by the urban dwelling Aedes aegypti mosquito, and I just wanted to mention the urban dwelling mosquito because unlike malaria, where it's a higher chance of acquiring it from going to rural areas, Aedes aegypti happens prevail in the urban cities, and people can get sick even if they go to like urban communities. And it's increasingly being recognized and reported in travelers. As we all know, 4 serotypes of dengue that affect human, and exposure and immunity to one serotype does not seem to confer protection to other serotypes. In fact, subsequent infection with another serotype may end up to be more severe and even fatal. One thing about dengue, short incubation period, 4 to 7 days. The presentation can be very wild, from just mild subclinical disease to influenza-like myalgias, the famous breakbone fever, lymphadenopathy rash, and of course, as we all know, can be complicated with hemorrhagic diathesis shock and can be fatal. And the diagnosis is usually clinical, but we do have PCR and serology to diagnose dengue. As we know, supportive treatment now. This map is meant to show the prevalence of Aedes aegypti. The yellow, where there is the mosquito, but the disease is not really that much reported. The red areas show where the mosquito is prevalent and dengue activity is reported. So you can see the region where people can get sick at. Viral hepatitis, just one thing to remember here, as more and more people are protected against the hepatitis A and hepatitis B, hepatitis E is being more recognized and should be considered. And also, one thing to mention about the hepatitis A, the vaccine or a previous infection confers pretty good immunity. So if your patient has a history of getting vaccinated or have an infection as childhood, if they come back with jaundice, it will just be less likely to be hepatitis A if they have that history. Enteric fever, typhoid, and paratyphoid, as we know, it's a fecal oral transmission. Incubation period can be short or up to 2 months. It's widespread, particularly in tropical areas, particularly Southeast Asia. And as you recall, when we looked at the data from GeoSentinel, the travelers who came back with typhoid fever most predominantly came back from Southeast Asia. And remember, it's a remittent fever, headaches, and may actually present with constipation rather than diarrhea. In contrast to hepatitis A, the vaccine is not that protective. So even if the patient has the typhoid vaccine, they can still contract the disease. Diagnosis usually culture. Serology is not that reliable, especially if the patient had the vaccine. And if you absolutely positive and excluded malaria and you have a prolonged fever in the right setting from the right geographical area, you can go ahead and do empiric treatment for Salmonella typhi. Again, very important to consult the guidelines. Resistance patterns change, and drug susceptibility should be checked if treatment is contemplated. Complications can be severe: perforation, abscess, toxemia, and intestinal perforation. Rickettsial diseases, again, when the data were analyzed, the people who had diagnosis of rickettsial disease as a cause of their fever, they mostly came from Sub-Saharan Africa. And that being said, it is a widespread disease, and the features that suggested is fever, headache, and myalgias. They are non-specific, but if you see an eschar in a fever from the right area, and it's not malaria, then rickettsial disease is up in the list. And also, that's a place where you may consider treating empirically, because treatment is simple with doxy. Meningococcal disease, devastating, bad news. Create a lot of panic in the community if someone is diagnosed by meningitis, Neisseria meningitis. And the reason for this phenomena is that the Neisseria meningitis tend to strike young, previously healthy individuals, and can be fatal. And again, large number of individuals get infected in a short span of time. Mortality can be high if the correct treatment is not commenced right away. And even with appropriate treatment, sometimes people end up with chronic sequelae. Of interest, the mortality and morbidity from meningococcal disease has not changed dramatically since the 1950s, and the main reason of that is our inability really to control the endotoxin-induced vascular collapse, which may lead to the patient demise. What about the incidence of this problem in the world around us? Large scales of epidemics still occur. They occur regularly in Africa, parts of Asia, South America, Soviet Union, and the epidemics are commonly used by serotypes A and occasionally serotype C. In the area known as the meningitis belt, epidemics occur maybe every 7 to 10 years. And the meningitis belt is an area in Sub-Saharan Africa, and I will just show you the map in a sec. And the case rate during these epidemics can be as high as 1 in 1,000 total population, and 1 in 100 for children. As we know, it's a disease that affects children more. And this shaded area here, basically Ethiopia, Sudan, Chad, Niger, Mali, Mauritania, up to way to Senegal, is what is often referred to as, you can hear of, the meningitis belt. Regular epidemics. Outside the meningitis belt, as you probably can recall, famous outbreaks from Hajj in Mecca, Saudi Arabia, where pilgrims will come back with meningococcal disease. And for the past few years, actually, Saudi Arabia requires meningococcal vaccines for all pilgrims, and the CDC continues to recommend the quadrivalent vaccine, but no antibiotic prophylaxis upon return. Bear in mind that if the pilgrim was vaccinated and he comes back and he is a pharyngeal carrier, they may not be sick, but household contact can get sick. Moving on to yellow fever, I tried to find what's the latest incidence of yellow fever. I guess the closest thing I could find was a WHO site, 1998 estimate, strikes about 200,000, kill about 30,000 per year. Again, the virus is mosquito-borne, the famous Aedes aegypti. It's a viral hemorrhagic fever, very characteristic hepatic and renal insufficiency hemorrhage, and the fear behind the yellow fever is just the fact that it has a high case fatality rate, so people die pretty easy. The disease occurs in tropical regions of South America and Sub-Saharan Africa. Again, travelers to this region, if you met the traveler before they get sick, they definitely require immunization. And we have a highly effective live attenuated vaccine, confers like 95% seroconversion rate. So immunization is recommended and advised to places endemic for yellow fever areas of Africa and South America. Just remember, it's a live attenuated vaccine that has some issues and side effects. So again, it's an case by case, and risk and benefits have to be weighed. Some countries even require valid certificate of immunization before entry to them, and the reason is they either have the disease is prevalent and you may get sick there, or they have the vector, and if you come from a region where yellow fever is present, you may spread it in their vector population. And this is yellow fever in Africa, basically around the tropics. In South America, tropical South America, Amazonia, Brazil, and Bolivia, Venezuela, Cambodia. Again, I said that, as I said, the fear of yellow fever is really the outcome, which is determined mostly by the second week. Either people recover pretty fast, or really they succumb to the disease, shock, delirium, agitation, multi-organ failure, hemorrhage, and death. Moving on to chikungunya fever, this virus is getting more attention because it's an emerging disease. I mean, there is more and more reports in fever in travelers acquiring chikungunya fever, which is caused by alpha virus that again transmitted by the Aedes aegypti mosquito. And the clinical syndrome caused by chikungunya virus mimics very much dengue. The only thing prominent is the polyarthralgia, which can be severe and sometimes even persistent for years after they get the infection. As I said, emerging infection, and has been increasingly reported by the CDC in travelers returning from Asia and Africa, 2006-2007. And people acquire it by going to famous countries for chikungunya like Kenya and certain areas in Asia, and hundreds of cases have been imported to North America, Europe, and non-endemic areas. The blue color basically shows the activity of the virus, and it's interesting because years ago when the virus was first showed activity, it was like Central Africa, and then it progressed to East Africa and then traveled all the way to Asia. So we don't know what next. Where next? Leptospirosis. Leptospirosis is kind of interesting because a lot of these sites or travel clinics that saw patients coming back sick with syndromes that mimic leptospirosis, they actually think that it's more common than actually being diagnosed as a cause of fever in people returning from tropical areas. One report in Dutch travelers, they went to Thailand and some other Southeast Asia. There were 32 cases over a 5-year period. And there was also a report, an outbreak in competitive swimmers in Malaysia in the year 2000, where 44% of the athletes met the case definition. And actually that river there, the Sigama River in Malaysia, has a 38% attributable risk of acquiring lepto. Doesn't look good, right? Remember?
Nice statistic.
Yeah, very. Fungal infections are also being recognized as causes of fever in returning traveler, acute histoplasmosis, acute cocci, people coming from Latin America, basically. And the risk factors include exploration of caves and excavation construction sites. A little bit more rarer diseases, melioidosis. It's a diverse disease entity caused by gram-negative rod, Burkholderia pseudomyelii, widely spread environmental saprophyte in endemic regions. And the risk of acquiring the infection occurs in the same areas. Predominantly Southeast Asia, South Asia, Northern Australia. The majority of currently diagnosed cases came from Thailand, Malaysia, Singapore, and Northern Australia. So as you can see, the dark red is highly endemic areas. You can see Southeast Asia, Northern Australia. The brown color where the disease is endemic. The lighter color is sporadic, and the light beige is where they isolated the organism from basically the environment. Just again, a very brief quick overview on melioidosis. Transmission is felt to be inhalational, sometimes percutaneous. Moderate incubation period, 9-21 days. The acute illness can be anywhere from like subclinical to fulminant sepsis, actually acute sepsis. The latent infection mimics TB. It can reactivate, causes pneumonia, osteomyelitis, septic arthritis, very much similar to TB, and the skin lesions can be from just flat papules all the way to abscesses. So if you have this presentation in someone from the right geographic locale, you really don't have other good diagnosis, it's something reasonable to pursue. Diagnosis, basically isolating the organism from a culture, blood, sputum, urine, abscess, and then further imaging if needed. And this disease, if you diagnose it, you want to treat it even if it's mild. Initial intensive therapy, followed by eradication therapy. As we all know, the organism is characteristically resistant to penicillin, first and second generation cephalosporins, Gent and Tobra. So typically we use ceftazidime or a carbapenem IV for 2 weeks. And then followed by Bactrim and Doxy for 3 to 6 months, depending on what site you're treating in the body. Just one word about actually Japanese encephalitis. Actually, one slide. Japanese encephalitis. I just wanted to show the area of prevalence of Japanese encephalitis. It's a traveler who comes back sick, encephalitic from one of these areas. It should be in the differential diagnosis, and it is vaccine preventable. Acute HIV infection, unfortunately, is still in the list of being acquired as an infection causing fever in a traveler, and now in these days, I guess it should be considered in the category of treatable infections, right? A couple of words about respiratory infections, because it is one of the commonest commonly can present with fever in a returned traveler. Now, the majority of URIs of respiratory symptoms in travelers are URIs, and they not really cause any fever. But fever, respiratory symptoms, influenza is always a concern. Other bacterial type of pneumonias, less commonly Legionella, Histococci, and Q fever. And I think there was a report in New England Journal of Medicine where they had travelers to Israel who had acute Q fever, pneumonia, fever, and all that. At the back of your mind, if all these diagnoses are secluded and the patients still have respiratory symptoms and high fever, they're coming from the right location, transit migration of larval helmenthes hookworm should be considered if they have cough, non-specific pulmonary infiltrates, and peripheral eosinophilia, what's known as the Loeffler syndrome. Having all that back in mind, I thought the most reasonable thing to do our clinical evaluation, as always, we'll start with history, but we kind of have to have a few basic concepts when taking the history. Still, the fact that cosmopolitan infections such as bacterial pneumonia, UTIs, are still among the commonest in travelers, and the traveler may acquire routine infections during their travel. They may be incubating an infection prior to their departure, or they may become ill upon their return. So to focus solely on unusual infections in distant countries may lead to mislead us sometimes. So again, common things in common, you have to consider that in your history. an examination. Again, non-infectious causes should be considered as a cause of fever in returning travelers. DVT, PE, drug fever. Because of what we've discussed about the incidents and location in different locations and all that, detailed history about all the countries visited, even if just passed through, if they are urban or rural. Dates of travel, duration of stay, very important, and means of transportation and accommodation. Activities, going in detail into activities and exposures during travel, sexual history, sexual contact, animal, arthropod, needle and blood exposures, and that doesn't need to be like IV drug use, or people get tattoos, may seek emergent medical care, have procedures overseas. Also the type of food and beverage, and also importantly soil and water contact, where and what they did and so forth. Host factors, always important to consider: age and sex, medical history, surgical history, splenectomy, HIV infection, gastrectomy, past infections and vaccines, because that's just gonna affect the probability of getting certain infections and such. Medications like chemoprophylaxis and pregnancy. Timing of exposure, it can be a powerful tool because it refine and limit the differential diagnosis, because basically knowing the potential, when the potential exposure have occurred, will allow us to calculate the incubation period. So sometimes if it's more than 1 month has elapsed in their tropical travel, many infections can actually be excluded. This is not meant to be, it's a busy slide, but as you can see, short incubation period: malaria, dengue, influenza, enteric fever, diphtheria, meningococcal disease. Intermediate incubation period: malaria still in the list, dengue disappears from the list, typhoid, relapsing fever, brucella, HIV appears on the list. Longer duration period: malaria still on the list, and now you see your acute hepatitis, schistosoma exposure, brucella, histo, syphilis, and of course HIV. Duration of stay is relevant just because of the probability of infection is directly proportional to the length of stay. For example, in one study among British travelers to West Africa, the relative risk of malaria was more than 80 times greater for stays 6 to 12 months compared to those of 1 week. That being said, one always have to consider that some infections are pretty quick to get. And again, some infections are just not possible in your returning traveler because they happen in people who are born and raised there, like lymphatic filariasis. They just take time, onchocerciasis, etc. So it would just be an improbable cause because of the duration of stay. Timing of presentation is also important. We want to see when these diseases actually present to the physician, and actually US Sentinel provided data on that. In their patients, they found the following. Dengue, majority of the time, 1 week after return when it was diagnosed. Malaria, falciparum malaria within 2 weeks. Vivax, longer. Hepatitis, even longer, 6 weeks at least after return. Acute schistosomiasis, it takes a longer incubation period, so the presentation is typically longer. In one study in freshwater swimmers in Mali, the median incubation period was 40 days. So that's something you would think will present a little bit later after returning from travel. Again, sex and travel, believe it or not, at this day and age, sexual contact with new partners is common during travel. And in one study, for example, 782 travelers were questioned about that, and 19% reported a new sexual contact, and 6% of these people had an STD. And in one survey among Peace Corps volunteers, only 32% actually used condoms, so barrier protection is commonly absent or inadequate. So what are the possible diseases if you get that type of sexual history? Syphilis, disseminated gonococcal infection, can all present with fever, returning to traveler. Primary HIV, hepatitis A, B, and C actually, CMV, and Epstein-Barr. The importance, again, of probing the history for vaccines and chemoprophylaxis comes from just probability of acquiring infection. As mentioned earlier, for example, things like vaccines for yellow fever, hepatitis A, very efficacious. So your traveler coming back with fever, if they got these vaccines, even if they were in areas where these diseases occur, will be just less likely to get them. On the other hand, typhoid, as mentioned earlier, is just not that protective. So if they come from an area and it seems like typhoid, even if they have the typhoid history, a typhoid vaccine history, you would want to consider the diagnosis. Also, malaria prophylaxis, bear in mind that really prophylaxis is not 100% effective. Yes, it will probably make it less likely, but it's not 100% effective. And also with the changing resistance pattern, they maybe they weren't on the right prophylactic medication. And again, Vivax, the commonly used chemoprophylactic agents, will not prevent a relapse of Vivax. And it can affect the time of onset. Again, people who, even if they had a history of vaccination in the past to certain diseases, just by having them, long time ago, may have that immunity waned off, and they may get these diseases. The most famous is rubella and diphtheria. The physical exam, one should look for with special care for skin, lymph nodes, retinal conjunctival change, enlargement of liver and spleen, genital lesions, and neurologic findings. And certain markers may tip us to pursue certain investigation types, such as if you find like pulmonary infiltrates or eosinophilia, may point to certain diagnoses. And the reason we mentioned all these different symptoms, signs and exam, is just because if you find a rash, it just limits your diagnosis. For example, malaria does not present with rash, at least in its uncomplicated case. Jaundice, again, there are a few things you're looking at. Hepatosplenomegaly and eschar in the right setting, that very suggestive of Rickettsial. And of course, hemorrhage, that's the one that no one want to see. Your initial lab workup should at least include that. CBC, differential, LFTs, cultures of the blood, UAN cultures, peripheral smear for malaria, and that's routine, basic, regardless of what you can see in the physical exam and so forth. So ill traveler will definitely need peripheral smear for malaria. Your other test, it really depends. Stool studies, you don't have to get them universally. You have to, go by your individual patients. Chest X-ray, serology, urinary antigens such as for Legionella, blood smears for other organisms like Babesia, Borrelia, and Filaria. And sometimes one may even proceed to bone marrow biopsy and aspirate, and that may be their only diagnostic mode in some of these tropical diseases. And then anything you can biopsy, skin, lymph nodes, other masses, and sometimes you may need CSF exams and further imaging. The differential diagnosis, so going back to what GeoSentinel found by analyzing all the data on their sick travelers coming back with fever, gave us a really nice limited list for specific diagnoses. Malaria, dengue, mononucleosis, EB virus, CMV, rickettsial infection, typhoid, paratyphoid. That's the bulk of their patients coming back with fever from the developing countries. Now, remember they classified them into different groups: febrile illness, acute diarrhea, chronic gastrointestinal disorder, and dermatologic disorder. The rest will not have a fever except acute diarrhea, but then you really have a site, so you can pursue further testing based on that. Signs requiring urgent intervention on your fever, on your traveler coming back with fever, hemorrhagic manifestations, respiratory distress, hypotension, confusion, lethargy. And remember, although hemorrhage bring to mind all these exotic viral hemorrhagic fevers, many infections can be associated with hemorrhage, include treatable infections such as meningococcemia, leptospirosis, plague, rickettsial infections, vibrio infections, and Lassa fever. So continue to pursue treatable diagnoses in these patients, for sure. Emerging infections, always a concern. Recent occurrences of the H1N1 pandemic, the SARS pandemic, the avian influenza. People are just more aware that emerging infections do occur, and other diseases of public health importance. Again, although just rare to occur, viral hemorrhagic fevers are still needed to be considered in patients who have fever and hemorrhage because of public health implications. So just to summarize real quick, this what we've went through. Basically, febrile illness is a common presenting feature in travelers, and it requires epidemiologic risk, clinical and epidemiologic risk assessment. Complete history and exam together with initial lab may give clues to diagnosis of a tropical disease, and an estimate of an incubation period help to narrow down the differential diagnosis. So it's a very critical piece of information. I just want to bring that sometimes unusual infections happen outside the United States may happen in odd seasons, for example, influenza in July. So you want to also bear in mind that familiar infectious disease acquired in tropical regions may just happen unexpectedly in an unexpected time of the year. And again, the summary for the GeoSentinel findings regarding their specific pathogens. Findings: malaria, dengue, mononucleosis, rickettsial infection, salmonella typhi. And again, in 40% of the time, they really didn't have a specific diagnosis for their fever in their travelers. Bottom line is, when patients present after travel to the developing world, travel destinations are associated with the probability of diagnosis of certain disease, and diagnostic approach and empiric therapies can be guided by these disease-specific differences. Useful resources that can provide current information about infections found in different geographic locations, CDC, travel, and the WHO website also has regularly updated information about outbreaks.